Your period is a vital sign. It should never disrupt your life. It should never cause you pain. A normal cycle should be regular. The most likely time a woman is going to commit suicide is between the ages of 45 and 55, and so much of this is preventable.
Dr. Mary Claire Haver, board-certified OB-GYN, 30 years in medicine, New York Times #1 best-selling author, breaks down what women were never taught about their bodies, from their cycle to fertility to perimenopause and menopause. Why has women's health historically been so misunderstood?
Modern medicine was built by men for men. The way we practice medicine was built on the male body as default. And
how early would you recommend people freeze their eggs?
The younger you do it, the better your chances are of having successful embryos or pregnancies from those eggs. Women go right from birth control to trying to get pregnant without ever understanding what their cycles are like.
Are women being prescribed birth control too early?
I think
Hi guys, Kate here. Thank you so much for tuning in to today's conversation with Dr. Mary Claire Haver. If you've been enjoying Post Run High or are excited about today's conversation, please hit that subscribe button. Your support helps us continue bringing you inspiring conversations. All right, let's get into it. Dr. Mary Claire Haver, millions of women have turned to you because they felt ignored by the very doctors that were supposed to help them. You've essentially become the doctor that they never had. So how would you summarize your overarching mission at this stage of your life?
It's a big shift in the way I used to practice. I am a very well-trained obstetrician gynecologist. I just realized as I was aging and my patients were aging, there was a huge gap in my knowledge. And it also made me realize there was a lot of bias built into the system and how we were trained. And I finally got to the point in my life where I stopped asking men for permission to do anything in my professional life. And I decided to focus on menopause. And I didn't know anyone who had done that. And really not just menopause, focusing on women's health outside of reproduction. And what does that even mean? There's no women's health specialty, right? It's OB-GYN, and we take care of amazing things, the breast, the uterus, the pelvis, pregnancies. But what about her heart, her brain, her bones, her muscles, how she ages, her geriatric life? No one's really looking at that. So deciding to focus on that and giving women the best health of their, last 30 years of their lives became my focus. But what I realize now is that starts in our 20s. And 30s and 40s to build that foundation so that we don't end up with dementia and osteoporosis and preventable heart disease.
And it sounds like what you're saying too is when it comes to female health, there really has to be a holistic approach taken.
Absolutely. It is not just whether or not you take birth control, whether or not you have regular periods. It is your lifestyle, your nutrition, your exercise, your stress reduction, your sleep, and really learning how to put yourself first. I mean, if the only lesson that your listeners and viewers come away with here is that they need to prioritize their own health, put that oxygen mask on first before they take care of anyone else in their lives, before they decide to start a family, that is the most important thing so that you can then turn around and take care of those people.
When you said before that you wanted to stop asking men for permission, Are you referring to also other men in the women's health medical space?
I mean, traditionally, it's just the jobs that I had taken, were all my bosses happen to be mostly male. And that's just the way the system was built, right? I've been in academics for 30 years. And, definitely I've had women that I've worked with and some of these men have been amazing, but I always felt like I could not make decisions for myself in my medical practice, that I had to go, could not step away from guidelines, had to go with permission to see a patient or permission to, when I decided to step away and open my own practice, build my own clinic, I didn't have anyone to turn to. I'd never done anything like this. I literally bought something similar to the Idiot's Guide for Opening a Medical Practice, and that I could build the practice of my dreams exactly the way I wanted it. And that was just something I didn't know I could do. And that's a lesson I'm teaching my daughters now is you can do whatever you want. You don't have to wait to have permission. I just grew up with imposter syndrome. I just thought, it was an accident. I got into medical school, so I had to work really hard and make the best grades and be at the top of my class. Otherwise, they weren't going to let me stay. It was an accident. I got the top of my residency choices, that I took that spot away from some other guy, and I had to work 10 times harder than everyone else to earn my place there. None of that's true.
Yeah, none of that's true. And it's amazing that even when you were getting to the top of X, Y, and Z thing, you had imposter syndrome.
Totally.
When did you find your voice online? Because you not only have an incredible practice, but you have become very outspoken online and millions of people trust in what you say.
I started kind of playing around on Facebook. I got on Facebook, I think in 2010. That was my first touch into social media. And it was really for friends and family. We had a very devastating hurricane that wiped out our town that I've lived in for the last 20 something years in Galveston, Texas. So we had a big hurricane come called Hurricane Ike, and we had lost our home. Most of our friends had severe damages, and joined Facebook as a way to communicate. We were sharing pictures and whatever photographs we could get of the island and just information. And then I realized, people are doing other things on Facebook too. So sometime probably 2012, 2013, I started talking a little bit about my job and started trying to educate on Facebook, created a Facebook page, a professional page for the first time. And I was doing little online courses on how to do that. It was a passion project. It was nothing that I was going to try to build a business around. I wasn't even talking about menopause back then. I was literally educating about your body, your periods, birth control, etc. But I was getting dopamine hits because I was getting more followers and more views, and it was exciting for me. So probably, in the early 2010s is when that developed.
Yeah. And I also feel like it's because for so long, conversations around women's health have been so taboo, where even saying, I'm going to the gynecologist or I'm going to the OB-GYN. I remember my mom used to kind of pull me aside and be like, without my brothers and dad listening, you have an OB-GYN appointment,
Yeah. And I think social media has become the water cooler for women in a lot of ways, where she said menopause. She said periods. Let's lean into this. One of the problems with these social media platforms getting so big and them having to police themselves is a lot of the female health content gets suppressed because we say things like proper anatomical terms like vagina, where they automatically assume it's porn. And I've got friends in the space who have to fight, Meta and fight, these big algorithms to allow them to advertise or even say these words that, hey, we're not talking about pornography here. This is women's sexual function. If a friend of mine, Cindy, owns a company where they sell an FDA-approved medication for libido. And she's had to really work with Meta in order to even get their ads out there because there's so much, policing around that when it's just our basic anatomy.
Just our basic anatomy. And I even think about that too. I'm currently 7 months pregnant. And even when I talk about the type of birth that I'm having, it's so much easier to say C-section, even though I'm having a vaginal birth. But it's the idea of saying vaginal birth.
Immediate flag, immediate suppression. Yeah.
It's so interesting. Why has women's health historically been so misunderstood?
Gosh, when I started digging into the literature, when you look at Elizabeth Coman's book, It's All in Her Head. When you look at Eleanor Cleghorn's book, there's a lot of great books that have been written on this, and they looked historically as to what was happening. So there's several things at play here. One, modern medicine was built by men for men, and most of them were Caucasian, right? The way we practice medicine was built on the male body as default, and anything outside of reproduction is abnormal in a female if we present differently. So one of the most famous examples is heart disease, okay? When men have a heart attack, in general, not all men, but it is the very Hollywood heart attack. So when I say heart attack, what do you think if you're going to see someone have a heart attack on TV?
Well, when you say Hollywood heart attack, I'm immediately thinking about, what is it?
Sex in the City. Yeah.
When Big has a heart attack.
Grab his heart, fall on the ground. Okay. When a woman has a heart attack, those symptoms are considered to be abnormal or atypical. Because we disease differently than men. Men tend to have disease in the very large parts of the coronary arteries. So they have this very acute, all of a sudden they're fine, and then they, climb stairs or they do something vigorous and it affects their heart, and they like grab the heart, they have pain in their jaw radiating down their arms. Women have diffuse microvascular disease way down deeper in multiple spots. And so they have fatigue, nausea. It goes on for weeks. They just don't feel right. They think it's indigestion. They think, because we weren't taught that this is how a woman presents with heart disease, atherosclerotic disease versus a man. And so we were always taught that this is atypical chest pain, though we're 51% of the population. Our heart attack should be typical. Men's are atypical, right? So that's so then that transmits to the ER. A woman comes into the ER with her heart attack. She's 50% more likely than a man to be misdiagnosed and sent home for indigestion, panic attack, anything but the actual physiology of what's going on. She's also much more likely to die from a first heart attack than a man. Now add in socialization. She doesn't put her health first. Oh, I'll go after I take care of the kids and my husband. I can't leave them. I can't tell you how many times in obstetrics this happens. A woman comes into the ED with an acute issue during her, pregnancy, but because she has other children at home, chooses to leave and not follow through with care because there's no one to watch the children she has. And so we're so used to putting our own health secondary to everyone else's needs that's part of it. And then the bias built into the system. I was taught, this is hard to say, that women tend to somaticize psychological issues. If we can't figure out what's going on with you, she must be a little crazy. And Elizabeth Coleman, who went to Harvard, calls this the bitches be crazy school of medicine. Women are just a little crazy. So if she's coming in with multiple vague complaints, and it's so typical in perimenopause. So I'll tell you a story from my residency. When I was an intern, my very first year, my first block was labor and delivery nights. Rock and roll. I was a fish in water. It was the most fun I'd ever had. Babies are flying out left and right. I'm catching babies. Okay, next 6 weeks is gynecology. And half of that time we spend in clinic, not a menopause clinic, in gynecology clinics. So discharges, hysterectomies, gynecologic issues. And we so all 4 years are there. We have 4 years of residency. So the upper levels get the charts. Now, that's how old I am. We had paper charts. They would run to the charts and find the surgical cases. They want to operate. They need their numbers. So they're grabbing all those charts. The interns get whatever's left at the bottom. Okay. And it would be this woman in her 40s or her 30s with multiple vague complaints. She's tired, more fatigued than usual. She's not sleeping well. She's maybe having some menstrual irregularities, maybe not. She's gaining some weight. Her libido's a little bit off. She's having some aches and pains, joint pains, whatever. She's having a little trouble at work, concentrating. And I look through the chart, like, what has she had worked up? Who's seen her? Family medicine saw her, endocrinology saw her, gastrointestinal saw her. No one can find anything wrong, right? Her labs are normal. So I go to my upper level because we have to check out, right? They're in charge of us. And I'd be like, oh, I've got Miss Smith. She's 43 with blah, 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 blah complaints. And he'd be like, what workup has she had? And I'd say, this is normal, da, 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 da. And he's like, you got a WW. And I'm like, what's that? And he's like, well, don't write this in the chart, but that's a whiny woman. Pat her on the knee, tell her it'll be okay, maybe offer her birth control, see if that'll help. And there's really nothing we can do for her. And now I realize, it took, I was writing the book and the story bubbled up again. And I'm like, she was in perimenopause. Like, she was in full perimenopause and we didn't know how to recognize it, to connect the dots, right? And so that was just, he wasn't a bad guy. He was taught this. He taught it to me. This whole system was propagated. I've talked to other doctors across the country. They're called status Hispanicus, total body dolor, whiny gynies. Like, this is pervasive across the U.S.
Yeah, and it's derogatory towards women. And in that moment, did you feel that?
Look, imposter syndrome. I felt so lucky to be there. And I'm like, okay. Am I embarrassed about that? Yes. Now, yes. But I was just out of my, medical school. So scared I was going to kill someone. So scared I was going to mess up at work. And, here's this like venerated person telling me she's a little crazy and there's nothing we can do for her. And so I just took it at face value. And it took really 20 years of practice to that part of my brain, to unpeel all those layers and realize this was systemic bias built into the system.
Right. And I feel like also, as a doctor, my aunt's an orthopedic surgeon, and everything that you do is so by the books. And then it's like it does take years of practicing and getting comfortable and seeing so many different scenarios and situations for you to start being able to make your own hypotheses on what's going on.
And, so much of what I was doing was OB. So much of what I was doing was surgery. When we got to perimenopause, I had no training, no understanding, no way to connect the dots. It took 20 years for me to figure this out.
So for someone that has never come across your work, tell us why it matters.
Because menopause isn't optional if we live long enough. 100% of us will go through perimenopause and then menopause simply by the aging process. And it is a normal transition. It happens to all of us, normal meaning common. But for so many women, it blindsides them and they end up suffering needlessly. And so my focus is to make sure that we provide enough tools, education, and support to get them through this transition where they remain functional and enjoy the lives that they're meant to lead.
For men listening, why should this matter to them?
Because all of the women in your life who you love are going to go through this, and it's going to affect them dramatically. So, for example, we see risk of depression and risk of anxiety increase 40% across the menopause transition. We see the divorce rate skyrocket. The most likely time a woman is going to commit suicide is between the ages of 45 and 55. And so much of this is preventable. So you listening to this and understanding what these hormone changes, how they could affect her, you'll just be a better partner in her life.
It's important for our male partners in every stage of our life, whether it be when we're PMSing, going through our period, or having a baby, or postpartum, or going through perimenopause and menopause. They have to know how to support us because it's going to affect them too. And what I love about you and what you're doing is we don't have to wait until we're 35 plus or experiencing perimenopause symptoms to start thinking about these things. We can educate ourselves starting early. So for the purpose of the conversation, I would love for us to just go through the different stages of a woman's life. Let's start with our baseline, potentially women in their 20s, maybe younger if this relates to you, but really for the purpose of women in our 20s, what should a healthy cycle look and feel like?
Sure. So your period is a vital sign. That is so important. And a lot of women don't understand this. It should never disrupt your life. It should never cause you pain. It should never take the life that you've built and not let you be able to lead it. A normal cycle should be regular, should be predictable. Okay, now if you are a 25-day cycler or a 32-day cycler, that's still within the range of normal. But you should be able to look at a calendar and say, I'm going to start my period here, I'm going to ovulate here, and my cycle is going to stop here. Month after month after month, whatever that looks like. And 28 days is average, but again, we're still 25 days is still normal, 32 days is still within the normal window. If that's not, and it should not cause you to get up in the middle of the night, like whatever products you can buy over the counter should manage your period. So if you're bleeding heavier than that, that's not okay. You shouldn't have to leave your job or your classroom. You shouldn't have to stay home because the cramps are so bad. None of that is okay. Those are all vital signs that something is going on in your body, inflammation, endometriosis, adenomyosis, PCOS, that needs to be evaluated as soon as possible. So if you can't predict your cycle to the day, and if it's causing you so much pain or disruption of your life, these are huge red flags that you should get evaluated immediately.
That's so interesting too, because I feel like growing up, I even like until you just said that, I had no idea that having a heavy flow or severe cramping was something to look into when it comes to your period. I always interpreted it as, and as somebody that's always had a relatively light period and an easy period, thankfully, to manage, I've always interpreted somebody having a more extreme scenario as just, oh, that's just how their period
Bad luck,
is.
Right?
Yeah.
No. Yeah, it is just how their period is, but it means that something pathologic is potentially happening, and we need to go figure this out.
What are things that women write off as just stress that are actually hormonal signals worth paying attention to?
So many things, and this is our entire lives. And so irregular periods, so polycystic ovarian syndrome, cycles that are coming too frequently, these are all signs that something differently is going on hormonally with you. So let me kind of explain what's happening. One of the biggest ways that the people born female differ from males is that women are born with all of their eggs in the ovaries. Okay. And if you think about it, the egg that made you was inside of your grandmother. Those were formed when we're embryos. So we start developing eggs as embryos. So like you were inside of your grandmother, your
It's
DNA.
so special, right?
Isn't that amazing? And so you're like, okay, thanks grandma for the good, for the good house.
Right.
So that mom's, eggs could develop as healthy as possible. So we're born with all of those eggs. They start deteriorating while we're still in utero. So by the time we're born, we're down to 1 to 2 million eggs. That's what we start with in general. Okay, some people have more, some people have less. By the time we're 30, so that's 2 years from you are down to 10% of the original egg supply. That's still plenty of eggs for most women. By the time we're 40, that drops to 3%. And full menopause represents the end of your egg supply. That's what that is. And then we go on for the next 30 years living without those eggs, if we're lucky.
First, I want to talk about birth control because I feel like as soon as we start getting our periods, shortly after, we start having conversations with our moms and our gynecologists about birth control. So I'm curious, are women being prescribed birth control too early?
I think I love having contraceptive options available to patients. Contraception was developed to stop pregnancy. It turns out it has other uses. It can be really helpful for acne, controlling testosterone levels, dropping those androgens so you don't see it in the skin. It can be extremely helpful in some patients for endometriosis, helping to control pain because we're dropping their estrogen levels. It can be really helpful for heavy periods and irregular periods. Like, we have lots of uses for this. Where I think we're going a little quickly is we're not working up the patients as to why these things are happening, okay? And I think women deserve centuries of research, but I think one of the areas is why are these diseases happening? What is the root cause of this? That contraception can be a Band-Aid and can give so much symptom relief, and I'm so grateful to have it available. But I think where we're not doing due diligence for a lot of women or younger patients is that we're not figuring out why this is happening. Oh, your cycles are irregular. Let's get on birth control. Oh, you're having acne. Let's get on birth control. Oh, and we're not thinking about downstream of, the long-term consequences of being on these medications for a long period of time. When I talk to my friends who are in the fertility world, they're like, women go right from birth control to trying to get pregnant without ever understanding what their cycles are like. And I'm the mother of 2 daughters who use contraception. And so, and they're happy to talk about it if, you can talk about them separately. But, I love having options for this. I think that we are utilizing it without doing the best workup that we could as to why this is happening, because that's going to affect endometriosis is not a disease of reproduction. This is a disease affecting the whole body. This is a pro-inflammatory disease. It puts her at increased risk for heart attacks, increased risk for stroke, and we're just giving her contraception to manage symptoms, which works for a lot of patients. But do you know that we're spending less percent of the NIH budget, on endometriosis, which affects 10% of the population horrifically. Yeah. So, polycystic ovarian syndrome, birth control pills control the symptoms of that really, really well. I'm a PCOS patient. I was on it for years and years and years. So grateful to have those things controlled. But no one sat me down and talked about fertility. No one sat me down and talked about, what this could do to my genitourinary system, my bones, et cetera. And I think we can do a better job at that.
I think so too. And so I actually have PCOS, and I didn't realize I had it until I was trying to get pregnant. And I kind of always had a feeling that something was there. I always had a feeling that I had something that was a little bit wrong, whether it was weight fluctuations happening, acne, irregular hair. I had all of these weird symptoms. And I remember being like, I must have something a little bit wrong, But I went on Accutane. It cleared up my skin. My skin then would always hormonally it would always come back. Anyways, I did birth control for a little bit, which helped manage some of the symptoms. And then when I was trying to get pregnant, I asked my doctor, I was like, can you just scan, do a check for me if I have PCOS? And sure enough, I did. And I had wished, instead of trying Accutane and, going on all of these different medications to kind of treat the symptoms, that I had kind of checked in on my diet, how my hormones were, what was really going on. I had, I have high androgen levels. I have a high testosterone. I have all of these things that are off that I feel could have been fixed in a more holistic way.
I think we're missing the boat here. Yeah. And I don't want to demonize contraception. There's a big push on social media, and I see so much in women's health that there's this birth control is bad and women shouldn't be on it and it's poison. And I'm like, I will never say those things.
Yeah.
But I think women deserve, the holistic approach, and, thank God we have these options. But like you said, you deserved probably a bigger workup and knowing what you were facing once you got off, and then we're trying to start a family.
So what are signs that your birth control, if it's an oral pill that you're taking or an IUD, is not a good fit for you?
So we have, dozens of oral contraceptive options on the market. And what most people should realize is that most of them contain ethinyl estradiol as the estrogen component. And so symptoms associated with, maybe too high of EE levels are going to be nausea, that's one of the biggest reasons I have to back off on that in the pill. And then there are probably last time I counted, 40 to 50 progestins on the market. So progestogens are progesterone-like compounds that bind to the progesterone receptors. And each of them have very, very different components. So we have like drospirenone, which is used in Yaz or Yasmin if you're, and there's a million generics on the market. So that one is better. It has a diuretic component, so it's better for bloating. It's really good for acne. Norethindrone's good for acne, but it does convert to estradiol, in the metabolic process. So there's so much nuance. And like on my podcast, we have a 2-hour discussion on all the different oral contraceptive options out there. And so that, things that I was taught in residency, pick a pill, any pill, they kind of work the same, and you can kind of fight through the different side effects. So I think we can do a better job educating our clinicians on all these different medications. And so, if you're having any symptoms at all, we need to change dose or change formulation or change delivery methods. So we have patches, we have gels, we have rings, we have so many different options. We have injections, we have progestin only options. I mean, they're literally, we could talk for hours about this, but I don't like when it's pick a pill, any pill, pick a patch, any ring, they're all work the same. You'll be fine. We'll just mess around. It can take a while to find the right combination for you that's going to work best with your body.
And 100%. And you hear about so many people switching between different types of medications and seeing what works for them. I'm curious how long, if you're somebody that's recently gotten onto a form of birth control and you're trying to figure out, is it going to work for me, or kind of in that waiting period, how long should that waiting period be?
I always tell patients a couple of months. Let's give it two packs, 2 rounds to see. Now, certainly if you were like in that first week, just like, I can't do this, then we're going to switch immediately. But in general, if you're okay, but let me see if this settles down a little bit, especially the nausea. Nausea does tend to get better. So if it's some mild nausea, it's like you're queasy, but you're not dying, let's give it 6 weeks, a month, and see in this next pill pack if this gets better. It really depends on what the symptom is. Now, acne takes 3 months to get better. It depends on what we're treating, right?
Yeah. And I mean, just for reference, for any girls wondering, I was on low estrogen and it really helped my skin. But I remember being so scared when I was going off of it. And I actually went off birth control, not even before trying to get pregnant. I went off of it like years ago, just because I wanted to start figuring out how to regulate my hormones normally. I had been through like 3 rounds of Accutane. It wasn't working. And I was just like, what is going on in my body? So anyway, I wanted to basically go off of all medications and just kind of see if I could treat this a little bit more holistically, which I ended up doing. But I'm curious, for somebody coming off of birth control, and I remember going down such a spiral of information because I was like, oh my God, am I going to get off birth control and my skin, is it going to purge? So that was my main concern. I know there's other concerns that people have.
Yeah, but that's important to you.
Yeah.
Yeah, my kids both dealt with acne.
So like, what can people expect in the first 3 to 6 months of getting off of birth control? And then what should they proactively be doing before they pull the plug?
So not all birth control is the same. Like if you have an IUD, then you should be ovulating normally in the background, right? IUD is meant to be locally acting, depends on what kind of IUD you have. It has the progestin in or it's the copper. And so once you pull it, it may take 3 to 4 months, like if it had progestin in it, to build that lining back up. We don't recommend pulling a progestin-containing IUD and trying to get pregnant right away, because we need to build that lining up for a nice, thick, healthy lining. So I'm telling my patients, wait until you go back to a normal cycle, like at what for you was normal amount, 3 to 4 days of bleeding, whatever that was for you before we put in the IUD. You want to go back to that before you try to get pregnant, because then we know that your lining has built up again. Copper IUD, I would say wait a full period before you try because it's copper and it causes an inflammatory reaction in the lining of the uterus. You do not want to get pregnant. It's a higher risk of miscarriage right after removing one. There's a lot of nuance. Coming off of oral contraception, if you're doing the Depo-Provera shots, it could be 18 months before you go back to normal. We've seen patients, it could be suppressed. Now, most are not that long, 3 to 6 months. And then oral contraception, it really depends on the patient. I have some patients who just right back to normal. It's like postpartum. Some people take months, years, other people they're pregnant, before they even realized, their period hadn't come back yet. So it's variable amongst patients, but we do try to give them rough timelines, but say you're an individual and your body may not listen to what I say.
Right. And then say becoming pregnant isn't even a reason you want to get off of it. You're just like me and you're like,
you want to be off of it.
Yeah, I just want to be off of it. What should you be doing in maybe the 3 months? Do you wean off of it?
You need to stop cold turkey. There's no weaning off of contraception. You get off and then you wait for your hypothalamus and pituitary to realize there's no hormones coming anymore. And then it starts cycling through the pituitary, pushing out the LH and FSH to get the ovaries to wake up again.
And what can people expect in maybe those 3 to 6 months post getting off cold turkey to happen? Well,
if you were treated for PCOS, you're likely going to be regular for 3 to 6 months, right? That's your most, because you've suppressed all the androgens that your ovaries were building up for so long. PCOS patients actually are the most fertile right after getting off the pill. And so now, that's not for everyone, but I'm don't be surprised if the hair starts coming back, the acne comes back, all the signs of the higher androgens, but that may take 6 months or so to do that.
Is there something that people can do to kind of manage those symptoms? What if you're like me and you're like, I do not want my acne to come back?
So fortunately, acne really, when we look at the everything that contributes to acne, diet, exercise, sleep, all the things that contribute to heart disease and to bone and muscle strength contribute to the inflammatory process in our skin. So really honing in on your diet, making sure, you're avoiding processed foods, elevated sugars. I mean, really the added sugar seems to be such a pro-inflammatory component and contributes to acne. So I just had a plastic surgeon on and I'm having a dermatologist on, and nutrition is really, really key here. And of course, topical products, to make sure you're limiting things that are really harsh on the skin that can cause inflammatory on top of the skin. You really want to use gentle cleansers and make sure your makeup and everything is clean.
Yeah. So it's really you need to have a good plan in place for when you go off of it, just to make sure you're treating everything as much as you possibly can. Yeah. I actually remember when I came off of it, I was actually okay, which was kind of nice, but I know for some people it's the total opposite.
It took, so I had a daughter who moved to the city in the summer and had stopped, and she's like, my skin is great. I'm doing so great. And it took about 6 months, and she was back in school, kind of she was living so clean, so healthy here, walking every day, Then she went back to college for her last year, fell into some of those habits, and by 3 months back, by October, the acne was back, the worst she's ever had it. So it was pretty she's got it back under control now. But I was like, yeah, what are you doing differently than what you were doing in New York? She's like, well, relying on more processed foods because I'm rushing for class, and not eating as healthy as I was, and not sleeping, going to football games, all the fun stuff kind of doesn't help our skin.
Okay, fertility. We've talked a lot about pregnancy, coming off the pill, things that can happen. I'm curious, at what age does female fertility actually begin to change?
So it's a continuum. It's a spectrum. So you are never more fertile than you are probably at 16 to 17, a couple of years of normal regular cycles, and you're never more healthy, right? Your body's not accumulating the hits of aging, exposure to chemicals, exposure to stuff. So fortunately, we don't want to be pregnant at 16, most of us. It's not optimal for most women, even though they're their most fertile. And so, but you are not. Your fertility at 25 is not the same at 30, is not the same at 35. Remember, our egg quality and quantity is declining every single day we're alive. And so now rather that reaches a point where, so when we look at fecundity, which is how likely are you to get pregnant at 25 versus 35? We see a dramatic uptick in the loss of fecundity at 35-ish. So we see everything kind of really starting to accumulate where that for the risk, the chance of you getting pregnant naturally, spontaneously, that really starts dropping off for most women at around 35 and really tanking at 40. But women get pregnant at 40 all the time.
Right. And I know we talked about this on our walk, but it's when I go to I'm 7 months pregnant, I'm 28 years old. I am like by far one of the youngest people in
So
the
cute.
doctor's office in New York, and it's because so many women are choosing to have kids later, which is, great to see that there are so many options and that it can still happen for you later in life.
So it really took me sitting down at that round table with Stephen Bartlett on Diary of a CEO and listening to, I kind of like dabbled in fertility when I was an OB-GYN, but like I would just refer to a fertility specialist. Like we used to say, give it a year. Do not do that, especially if your periods aren't regular, if you're having pain, if you're not having that predictable, painless monthly cycle, get in to see someone immediately. And it may not just be your regular OB-GYN. You may need to see a fertility specialist to go ahead and get that testing done. If you have a family history of infertility, your mom, your grandmother struggled, couldn't get you should look into this and see why it's happening. So much of endometriosis does not get diagnosed until you are trying to get pregnant. So if you take a woman who goes into her doctor complaining of pain with her cycles or, pelvic pain, if she's trying to get pregnant, she's more likely to get diagnosed years sooner with endometriosis than if she just goes in complaining of pain. This is a problem, right? We are missing the diagnosis of endometriosis, missing polycystic ovarian syndrome. These are not only do they affect fertility, these diseases affect heart attack rates, stroke rates, chronic health problems.
Yeah, and endometriosis, now that I have a couple of friends that are trying to get pregnant. One of my friends does have endometriosis, and it is so true. She didn't know about it until she was kind of at this stage of trying to get pregnant, and then it's like, oh, you have to get this surgery, and X, Y, and Z things are happening because you have it. It's scary.
It is scary. And, when you look at the tremendous lack of funding that goes into this very, very unique disease process and all the downstream effects that it has, it's really something we have to fight for, is mandating funding for these diseases.
Is endometriosis genetic?
It can be. There's a genetic penetrance, meaning if your sisters had it, you're much more likely to have it, but it doesn't mean you're not going to get it, if no one in your family had it.
So I remember when I was going into the process of getting pregnant, and I got pregnant really quickly, but I remember I'm just like a total worry freak. And I was like, oh, it's going to be so hard for me to get pregnant. I remember telling all my friends that are nurses, I was like, it's going to be so hard for me. They were like, I don't know if it is, and I was just kind of like speaking nonsense, and Jeremy's laughing at me because I was convinced my husband it was going to be like a challenge because everybody talks about it being so hard and I have PCOS and whatever. So I'm curious because then I asked, my aunts and my mom, was it hard for you to get pregnant? Now keep in mind, I'm a twin. So my mom was like hyper fertile and she was like, no, it was not hard for me to get pregnant. So for women out there that maybe haven't asked their parents yet, is it true that the way your mom gets pregnant and your, relatives like your aunts and grandparents, is that how you get pregnant too?
It's not 1-to-1.
Okay.
It's definitely not 1-to-1. I am one of 8 children. So my mother and father had 8 biological children together. I mean, she would look at him and get pregnant. And, and she had babies in her teens, 20s, 30s, and 40s, like this 22-year stretch of getting pregnant, staying pregnant, and having babies. She never had a miscarriage. And, here I roll up with polycystic ovarian syndrome. My first pregnancy at 31, miscarried. And she was like, well, that was bad luck, and then my second pregnancy, multiple complications, finally made it to barely term, had a baby. And she just was like completely like, couldn't understand how this could happen to me because she had it so easy and all her sisters had it so easy. So I blame my dad.
Interesting. Yeah. Well, the really hard thing about pregnancy, and, now that I'm at the age where I do have friends that are trying to get pregnant and I have friends that have recently gone through their first miscarriages, is you look at some people that my mom's one of 5, same thing, I'm one of 3, you're one of 8. It's like, and they never had issues getting pregnant. They were able to have all 5, all 3, all 8 of their kids, no miscarriages, whatever. And then there are women that have, multiple miscarriages, still go on to have healthy pregnancies and healthy babies. But It's so awful.
Well, and it's so much of it is like, oh, it's just bad luck. There's always a reason. There's always a reason, right? And like whether you want to pursue the reason is really up to you. But I think we're not giving out the best advice that wait a year. Oh, this happens all, there is a reason this is happening. And maybe it's something that was preventable and we're not really doing due diligence by the patients. I just have so many friends, like you said, who like wait so long and just take things for granted and would have frozen eggs, would have, taken steps had they have known that this might have been an issue for them.
What are the most common reasons you see women having miscarriages?
So when they've gone and I haven't looked at the data recently because I stopped doing OB about 8 years ago, but when, at that time, it was chromosomal abnormalities. So when they looked at, the products of conception, the, fetuses or, they do the DNCs, almost, a huge percentage of them had a chromosomal abnormality. And most of that is due to this aging egg phenomena. Now, more like Down syndrome babies are born to younger women because more younger women have babies, but the percent of babies with chromosomal abnormalities increases with age.
So there are real benefits to either egg freezing or having babies younger.
Yeah. It's easier. And you have the healthier eggs that have less chance of having accumulated chromosomal abnormalities. Not just Downs. There's lots of trisomies and
oh yeah. I mean, there's so much that can go wrong with fetal medicine. I almost feel like a lot of fetal medicine is still very archaic.
I think you're right. I think we're getting better. But I know younger patients are really interested in egg freezing now. I mean, really for the reason of once you do it, then you take that off their plate. There's no rush to get into a relationship or hurry up and get married or hurry up and like try to start a family, before you're ready. You have that in reserve. Now it's expensive. It's not for everyone. But I think more younger patients are considering it an option so that they don't have pressure while they're trying to pursue their careers.
How early would you recommend people freeze their eggs?
So I've talked to fertility. Again, I'm not an egg freezer, but when I talk to the fertility specialist, I mean, no, the younger you do it, the better your chances are of having successful embryos or pregnancies from those eggs. And so, I know patients as young as 25 who are still like deep into education for their careers who are considering having it done.
I feel like I had a friend in college whose dad's in the medical field and she froze her eggs when she was like 22. And I remember thinking, damn, that's so young. But
I mean, I was resistant to the idea at first. I'm like, oh my God, you're so young. You should be thinking about this, blah, 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 blah. And then I sat on a panel for 8 hours with the fertility specialist and was like, I'm going to call my kids and see if they're down for this. So if they want to learn more.
Right. And what goes into egg freezing? Like for people that know, because I feel like we hear all the time egg freezing and sometimes there's people on social media that document their journey, but I still am like, what are we actually doing?
Yeah. So basically the process is you want to get as many eggs as you can and still not have it not be dangerous. So that's generally going to require, I mean, you can do it on a normal cycle and just pull out one egg. Okay. That's really not hedging your bets. So you want to do it in the short a time as possible and get the most eggs that you can. So that's going to require stimulations. You're going to have to take medications for a couple of weeks to stimulate more eggs to come to the party. So those hormones we talked about earlier, they're going to give you FSH, which will force more follicles to try to ovulate and get them out so that you can retrieve them. So it's called hyperstimulation. So you're going to hyperstimulate the ovaries to try to get, 5, 10, however many you can out of one cycle. Then you go into a surgical procedure, usually done transvaginally, where they take a ultrasound probe with a needle on the end and they watch where the ovary is and they take the needle and they suck the eggs out of each follicle on both sides. And then there's an embryologist there who examines the eggs to see what the quality is. And then they pick the ones that look the most healthy. They can do testing on them if they need to. And then they freeze those for future use later.
And then the future use looks like what?
That's where it gets a little fuzzy for me. You'd have to talk to a fertility specialist, but I assume defrost, and either they can do an IVF procedure where they would then take sperm from your partner or from a donor and then, try to get the embryos and then implant the embryos back inside the uterine cavity. But again, that's a whole level of training that I never did.
What do you think women that wait to get pregnant wish they knew earlier on? at maybe 28, 27?
That maybe your fertility should never be taken for granted, that your period's a vital sign, that there are signs that this may be a struggle for you, that everyone says, I would have started sooner. I would have not put this off. I would have, if that is that, if being a mother and having your own biological children is important to you, and at any age, if you are not having predictable, painless monthly cycles, you need to go in and get evaluated. Also, not all fertility issues are female. And so the woman takes the blame for everything. Go get your partner treated.
Oh, yeah. And I mean, there's so much planning that goes into getting pregnant. I feel like I had no idea even before we.
50% of infertile couples, it's like close to 50% is male. There's a male factor. So like, don't overlook your partner.
And rare diseases, genetic diseases, like you have to get blood work done to make sure you don't have anything that kind of pops up between the two of you, right? That increases your chances. There's so much that goes into it. Okay, so hormones when we get pregnant. So I talked to my sister-in-law about this, who's 41. She has 3 kids. And she was saying that it would have been good. Obviously, this is hindsight is 2020, and I did not do this. But she was saying it would have been good for me pre-pregnancy to know what my hormones baseline was.
Like a serum level, like a blood level?
I guess so.
I mean, that's good in theory, but remember, we don't live in a steady state of our hormone levels. There's no baseline, right? So when we're like trying to see if we're worried about your fertility, we're going to check a day 3 level, day 3 of your period. That is when your estradiol levels are the lowest and your FSH levels would be low. So everything is really done with this caveat of, is she going to have trouble getting pregnant? Instead of, what is her peak estradiol level typically? What does it drop to typically? We know basic ranges based on population studies, but no one's checking that for you. But remember, estradiol has a baseline and then it surges at ovulation, then it drops off. We have a second kind of ovulation as progesterone goes up. It's not a steady state. So that is not something we do regularly to say, really, it's like when you're postpartum, how do you feel? Are you back to normal? You know your body better than any lab test. And so if you don't feel like your energy is back, you're sleeping back, you have a newborn, And so that's kind of weighing into the picture. But especially if you're older, we are seeing legions of patients go right from postpartum into perimenopause. So they never get back to their, what do I feel like baseline? And then we're adding in a newborn care on top of it. So now you're perimenopausal with a baby who's 100% dependent on you. So it is hitting, postpartum perimenopause is hitting patients so much harder than it would have at 20.
And then what are, like, when we talk about perimenopause and then having a kid kind of in that same time frame, what are the long-term effects of maybe having a kid later versus earlier?
So one of the things that I just read that really just blew my mind is that in the postpartum period, when we are nursing, this is a low estrogenic state on purpose, right? And we are meant to nurse our babies. I am not saying don't nurse, but we have a lot of bone loss. We have this acceleration of bone loss. And if you go right from that to your perimenopause is another acceleration of bone loss. And so it is so important that we get baseline bone densities on these women because they are getting a double whammy. If you're 20 and you nurse, the bone loss you experience from nursing will come right back. But we're not seeing that in the perimenopausal patient. She's getting hit twice back to back and then never able to recover. And so there are, bone loss is preventable. There are things we can do, your vitamin D, making sure your calcium, the weightlifting, the training, and hormone therapy, all of that can protect your bones, but no one's thinking of this. And I think this is one of the next frontiers in medicine for osteoporosis prevention.
Absolutely. And it's so nice that, there's people like yourself that are speaking about it and educating women so early because, we had talked about this too on the walk and we alluded to it in the beginning, but I feel like a lot of women's health almost blindsides us. Even like getting your period at whatever age it is, 10, 12,
we're
13.
all like, I'm dating myself, but Blue Lagoon was a really big movie when I was like, Brooke Shields and I are roughly the same age. I don't know her, but I remember her like getting her period in the lagoon and like she thought she was dying. Like no one had prepared her for puberty. And so then I feel like we're all Brooke Shields in the Blue Lagoon, her character, as we go through perimenopause. No one has prepared us for this. I was blindsided. Like and it was all retrospective for me. I was Not okay. I was like raging. I was yelling at my kids. That was the closest I ever came to divorce. And I'm all like, what was that about? Like I love him. Like we have a 33-year relationship. And I'm like, oh my God, that was perimenopause. And we're just letting women do this without any help or understanding. This is crazy.
Okay, so what is perimenopause?
Okay. So perimenopause medically is defined as the transition from normal menstrual cycles to full menopause. Like that means nothing in real time. Basically, think of the hormonal signals from the brain we talked about on the walk. So when we reach a critical egg threshold level, the signals from the brain no longer work on the ovaries the way they used to. So what used to be day 14, you're going to do this. Day 28, you're going to do this. Day 1, you're going to have your period. Because we're not getting the same feedback loop, you start going into chaos. The brain starts working harder and harder and harder to force the ovaries to push out those eggs. We end up getting hyperstimulation. And so in what we call loop ovulation, so we get double ovulation some months, where you get these massive surges of estrogen. Progesterone can never quite keep up because we're not having enough follicles recruited. And so what used to be very predictable, EKG-like, right, month after month after month, now becomes a zone of chaos. So those 4 key hormones, FSH, LH, progesterone, and estradiol, lose their predictability. We start seeing massive surges, massive crashes. And so this very, very hypermobile curve. And so the brain hates that. Our neurotransmitters, how we utilize glucose in the brain starts changing dramatically. This is happening to 100% of us. So quite often, the first symptoms are not your cycle being disrupted, not general urinary symptoms, not hot flashes, but mental health changes, sleep disruption, and brain fog. So there was a great study that came out last year called, I just don't feel like myself. I don't feel like myself. And I can't tell you how many patients came to me. And I knew these women. I worked in a small town with a big university, okay? These were PhDs. These were moms in my mom groups. These were women I went to church with, women I went to dinner with, women I did book club and running club and all the things with. I knew them. I knew their bodies. I knew their habits. Nothing had changed. But there was something internal changing, and we didn't know how to connect the dots and say, this is probably your hormones, or at least there's a component here that we should address.
And how early have you seen this start?
I mean, for patients with premature ovarian insufficiency in their 20s, it can happen young. But on average, somewhere between 35 and 45, you're going to start noticing there'll be signs.
Oh my God. And I said this on the walk. I can't, 35 is way too soon. I feel like I'm just getting on top of my period. I still feel like a little kid on my period because when I was on birth control for so many years, it was like I didn't even get it. I skipped my sugar pills and now I'm
I did too.
Right?
I love not having a period. It was amazing.
Why is being a woman so hard? It's like, all these different stages of life. It's like crazy that we go through. With perimenopause, how do you treat those symptoms?
Yeah, great question. So we have 2 options, really, if we're looking at hormonal treatments. We can treat symptoms individually, but then you end up on polypharmacy. You end up on something for your palpitations, something for your joint pain, something else for your, a sedative for your sleep. That is not the route to go. I don't recommend that to anyone. So now we're looking at hormonal options. Old school, anybody who was treating perimenopause was birth control pills only. We're just going to override the system, shut everything down, and calm her down. For a lot of patients, that works, okay? If you need contraception, if you're having heavy periods, birth control pills can be a really great option for people. If you're having pain, it can work, okay? It is a Band-Aid. We're not treating perimenopause. We're just minimizing the symptoms, which for some women, that's fine. Or we can try menopause hormone therapy, definitely for the mental health. And it is clear that International Federation of Obstetrics and Gynecology has been very clear on this. Transdermal estradiol and menopause hormone therapy is the way to go. That is going to be the best thing because we're taking the amplitude out of the craziness of the chaos. You're still ovulating in the background. Menopause hormone therapy doesn't stop ovulation. It's not birth control. So don't use it for contraception, but it can take some of the chaos, the amplitude out of these wild swings so you can function better. But you're still having some hormone stuff in the background.
And hormone therapy, there's been misconceptions around it for years, right? And is it true that people think it causes cancer?
Yeah. So that has been disproven. That was a study that was before you were born, probably, for a lot of you were born who were listening, that really kind of went viral before the internet. And it was the number one medical news story of 2002. It scared the bejesus out of women and their clinicians. It was, the findings were really misinterpreted. The risks were massively overstated. The benefits were understated. We know now a lot of that's been walked back, that for the vast majority of patients, hormone therapy is safe, efficacious, especially in early perimenopause and menopause.
And what does hormone therapy look like? Is it literally an infusion? Like, is it an injection?
Oh, good question. So we have, when we look at it, we're looking at 3 hormones and how to get it into your body. So there's the estrogens, the androgens like testosterone, and the progestogens like progesterone. So in modern menopause care, most of us for menopause hormone therapy, which we might give in perimenopause, is using estradiol and progesterone. We're trying to give you back exactly what your ovaries used to make, or used to make at a certain level. Okay. And so how do we get that in your body? We have to look at them each individually. So for estrogens, most of us are using just estradiol. We can do oral or non-oral. Oral is a pill, easy, right? Non-oral could be a cream, a patch, a gel, a pellet, a shot, an injection, a ring that puts in the vagina. So we have lots and lots of options. It is not cookie cutter. It is not one size fits all. Most of us are using oral micronized progesterone for our chosen progestin. About 10% of patients don't tolerate it. So I love having options. So then we're going to use something like a combi patch or an IUD to protect the lining of the uterus. So if you have a uterus still, if you give someone an estrogen, you must give them a progestogen to protect the lining of the uterus. But progesterone is also great for sleep. So it's optional. It's mandatory with the uterus, but optional without one.
Wait, what do you mean if you have a uterus still?
So some women have hysterectomies or were born without uteruses, or have a progestin-containing IUD, but there could be a role for an oral progestogen.
Okay, because I thought for a second you were going to say like your uterus goes away.
No.
I was going to be
boy,
like,
that would break the internet, right? So no, it doesn't go away. But if,
it disappears.
A huge percentage of women end up with hysterectomy. It's getting better, but like 25, it was the most common surgical procedure after a vasectomy, So, it's a huge percentage of women end up with hysterectomy. So always, they're like, oh, my doctor said I don't need a progestin. I don't have a uterus anymore. It was removed. I'm like, we can still talk about it. It's not mandatory, but it's optional.
So you have a new book coming out very soon. Your book is sitting behind you. I don't know if you guys can see it if you're watching, but it's The New Perimenopause. What inspired this book, and what is something that you learned while writing it that really surprised you?
So I wrote The New Menopause, right? And it was a New York Times bestseller, #1 New York Times bestseller, and really, it had legs like crazy. We stayed on the list for 6 months, and it's still selling like crazy. It's like in book clubs and everything. But there were the perimenopausal people, and they keep coming. Like everyone's aging. I keep getting new patients with perimenopause. Like, what about me? What about me? And it's really its own distinct biological transition. And it's really a guide on how to get ahead of this, right? How to educate yourself, lifestyle. We go hard on lifestyle and nutrition, exercise, stress reduction, all the things that we know work to help you build that foundation so the transition can be minimized and you can get through this. And then all the hormone therapy options, how to talk to your doctor. And it just really, it's not the waiting room for menopause. It deserved its own book.
Because when you say the waiting room for menopause, it's kind of this middle stage, right?
Right.
So how many years typically is
7 to 10?
7 to 10. That's a long period of your life. And if you're just chalking it up to being
I'm a little crazy, I'm stressed. But women are getting divorced. They're quitting their jobs. They're changing the trajectory of their lives over this. This doesn't have to happen.
We reference this on the walk, so I want to dive into it a little bit deeper here too, is, you mentioned certain things that have to do with like longevity and aging. And we were saying that the conversation around longevity is very broad. It kind of loops women and men together and says there's X, Y, and Z things that you can do to age in reverse and age backwards, whatever. We've had Brian Johnson on that does all the different things from red light therapy to Chiro and, whatever. So let's talk about longevity and aging as it relates to perimenopause.
So when my patients come to me, usually it's put out this fire of menopause, perimenopause, like get me back so I'm functional. Okay.
Put out this fire. Oh.
Then, so we put out the fire. She feels like she's got her life back, Then she's like, okay, I'm like, let's talk about the next 30 to 40 years. How did your mother age? How is she aging? How about your grandmothers? What about your aunts, your great aunts? Like, how are the women in your family tackling that last decade? Okay. Women win the longevity race. We are going to live 6 years longer than our male twins. Okay, we win. All right, Brian Johnson, just by breathing, I'm going to beat you. All right. However, I don't have a single patient who wants to live to 120. Not yet, not one. She doesn't want to be a burden on her family. She wants to live as independently for as long as possible. She doesn't care about the quantity of her years. She cares about the quality. That's where we have so much room. And it's not all these esoteric, those are sprinkles. It's not the peptides. It's not the cold plunges. Those have not been meaningfully shown to extend a woman's life. Okay. What does? Nutrition, exercise, connection, using your brain. I've had gerontologists on this. Have someone who actually takes care of the elderly and talk to them rather than these people doing all these crazy protocols. Like the women who are taking care of the women who are aging, all say the same thing. It's joy. It's connection. It's using your brain. Those are the things that are most predictive. It's fiber intake. Most predictive of a woman living independently, long and healthy, and not smoking and getting adequate sleep. Those are the core things. If you're not doing those things, it doesn't matter all of these little esoteric, how much red light therapy. And I like red light therapy, I hate being cold. I'm not getting a cold plunge.
The same way.
Like those are not the things that are working for us.
Right. Even the things that you mentioned, they're so primitive too. It's like simple,
and I do track. Yeah, I like tracking.
Yeah, you got the Oura ring.
I've worn the glucose monitor. No, it's a bad boyfriend for me. It makes me feel guilty. It doesn't, I don't recommend those unless you're pre-diabetic. It's an interesting tool to learn about yourself. And I don't need this. This is making me crazy. I like my sleep monitor. Whoop's a really good one as well. The band bothered me in sleep, but I track my sleep because it's taught me about the things that are affecting my sleep. If I'm not getting good quality sleep, I'm at high risk for dementia. My mother and my grandmother were terrible sleepers, both ended up with Alzheimer's, and we don't have the gene. So what are the lifestyle things I can do? And it is not the cold plunges or the peptides. It is literally sleep hygiene, limiting my alcohol intake close to bed, making sure I'm getting my relaxation in, I'm taking a hot bath, I'm doing the things. I do like a sauna blanket. It does tend to help my sleep.
When you say using your brain, because I really like this one, because I really do, I think it is important for women to stay cognitively active in whatever way.
Knitting, mahjong, taking courses, women who stay volunteering, talking to people, getting out there and living their lives. Part of probably why my mother's Alzheimer's got so bad, she isolated herself in the last 5 years. She lost my dad and 3 of my brothers. So that's also what I'm coming from, is 3 brothers who didn't make it past my age right now, 57, and then my dad died of COPD related causes. And, my mother really just locked herself in a room and was depressed. And I just watched the mental decline after that. And so those are the things, it didn't matter. If she would have sat there and cold plunged all day, it wouldn't have mattered.
And it's also as hard as it is to go through the loss of a parent, it is important to look at their life objectively and say, okay, they passed away at this age. What were the things that they did in their life that maybe I could adjust in my own?
Yes. And not blaming them, because my grandmother followed the advice they were given. They tried to stay thin, and they didn't exercise the way I exercise. They didn't eat the way I eat. They ate a lot of processed foods, and my mom especially. And, I'm changing those things. I don't want this to be the biological inevitability for my daughters. So I'm experimenting on myself to show them the way.
Yeah. And there are so many things that women have to do differently than men when it comes to fueling our bodies, making sure we're staying strong. I know we talked about osteoporosis. If you want, we could dive into it a little bit, but we have a lot of runners that listen to the show. And I know that you asked me if I've ever checked my bone density, which I have not. And now I feel like I should.
So not all runners, right? But the more longer distance ultra marathoners tend to have more problems with osteoporosis. So, it really shocks my patients who have been incredibly fit, who then get this surprise diagnosis of low bone density, and they're like, what?
Yeah.
And so we think the latest papers I've read, I just looked at this week for a friend. It's chronic underfueling. Because you're spending so much time exercising to do these longer distances, you're just not able to keep up with the caloric intake, and that is chipping away at your bone and muscle strength. And so it's not, early intervention. So Hormone therapy is FDA approved for the prevention of osteoporosis. And so especially if you're a runner in your 40s and you have a baby and you go right from perimenopause to postpartum, like all runners, I think should just get a baseline bone density at 35 and see where you're at.
What are the best workouts for women?
Oh, yeah. So if you're sedentary, walk. If you're sedentary, if you walk 30 minutes a day, I will cut your risk of diabetes by 50%. I will cut your risk of stroke, cut your risk of heart attack dramatically. Okay. So say you're a walker, load your walk. Put on a weighted vest. You're going to, have other improvements. You're going to put more load on that bone and muscle. You're going to probably decrease your risk of osteoporosis. You are now, if you're already walking, pick up some weights. So increase your cardio. So like the perfect workout probably for women is very complicated, and it's going to be at least 150 minutes of cardio a week. I just read a study that said 300. I'm like, girl, we have no time for this. 100. So 5 30-minute walks a week. You need to add some sprints in there to get that VO2 max going. Okay. And it doesn't have to be long, 3-4 minutes, a couple of times a week. You need to probably do some jump training to protect your bones so that, there are little fluid capsules inside the osteoclast that when we bounce and pound on them, we send a signal to make the bones get stronger. When we have load pulling, when we're doing weightlifting, I've totally changed I used to work out to be thin, step aerobics, all these things. No, I'm doing all my Zoom calls are on a walking desk at work when I'm doing stuff for business, when I don't have to be all, made up for podcasts and stuff. I'm walking with the vest on an incline because I have a place in the mountains. I'm training also for my walks in the summer when I'm walking in the mountains, like at 10,000 feet and climbing 2,000 feet.
I love an incline walk on a treadmill, by the way.
Yeah.
Such a good workout.
It's such a great workout. I'm hitting so many of my goals. I'm so lazy. I'm trying to stack everything when I can. And so, and then I'm doing 3 solid days, if not 4, of weight training. So a push day, a pull day, a leg day. I am just trying to hit all the major muscle masses. And it's so fun because I've been so thin my whole life to watch my muscles grow, to watch the scale get heavier and not freak out about it and be like, oh my God, that's my bones and muscles. Doing regular body composition scans, how much of this weight is this 128 pounds is muscle, is bone, is fat, is visceral fat. And knowing that those are within my control by my lifestyle is amazing.
What I love about doctors too is you guys take, even my friend that's a nurse, she takes such a scientific approach to her body, and like how she trains and how she cuts when she wants to, cut some weight, gain weight. It's really interesting. And it is cool that your body really does come down to a science. So you can train properly to fuel.
So now I'm training for my old lady body, not for a bikini. I'm training to be unbreakable.
But we should all be training to be unbreakable. It's never too early to start.
Never too early. And if you can lock those habits in at 20, at 30, at 40, my kids are in their 20s. I am trying to preach to them. It is still mom. They're not really going to listen to me. I'm just trying to get them to wear sunscreen, I get it. You're invincible at 20, but I think most of us in our 30s start realizing, I'm not invincible. Things start hurting, things start breaking. And so, but locking in those habits as early as possible is only going to serve you in the long run.
Okay, so pregnancy training, since you were an OB-GYN, or you are an would you say you are an OB-GYN?
I'm still board certified, but I've dropped obstetrics for my practice.
Yeah. When you were an OB-GYN and you had pregnancy patients come in, I know there's people have different beliefs on this. What are your thoughts about training while pregnant?
It is not the time to start training for the first time for a marathon.
Yeah.
Right?
Hard stop.
Hard stop. If you're already a marathoner, you can keep running. I'm just looking at your pelvic floor. If you start leaking urine, you should probably back off and work on your pelvic floor and see a pelvic floor physical therapist because you're running with a lot of weight now on this very tenuous hammock. There's no bones holding our girl parts in. Everything's pushed up. Your VO2, your tidal max is different. Like lots of things change. But God, telling a woman she shouldn't exercise at all is going to cause all these things. I'm like, no, we need to, you're training for nothing is going to tax your body more than labor. It is your marathon, and so you need to be as healthy as possible for it. And exercise is part of that.
I feel like exercise has helped me so much throughout the pregnancy. Even now I'm, 7 months in and everything's getting harder. Like when I do my running interviews, when people still want to come on and run, I'm like, oh my God. Because it's so.
You're growing a kidney. I mean, like you just grew an eyeball and you're trying to run. It's hard.
It's hard. And you just get so much breathier and literally like all your organs get pushed up. It's harder for me to talk and run. But I do have to say, I feel like it would have been so much worse had I not kept my activity level up.
So, horseback, things where you would fall or bats and balls would fly at your abdomen. These are not the things you want to be doing so much in pregnancy. But, as long as you're not risking tearing the placenta from a traumatic injury, you should be okay.
Yeah, that's the big thing. Tearing the placenta, the abrasion or what. Yeah. You don't want to fall. And then your balance does get worse.
Balance is a lot harder. So make sure, ladies, you're holding the rail when you walk. Like, I can't tell you, don't climb a ladder when you're very pregnant. Like, not okay. Like, hold on to the rail when you're going up and down the stairs. Non-negotiable. Don't be carrying the laundry or whatever, like that needs to go out. You can't see. Your balance is different. Protect your balance.
Yeah, I even like when I'm in a workout class now, I go to this class called Soto Method, which I love. And I feel like I really leaned into it during pregnancy because the founder of it trained on the app that they have throughout her entire pregnancy with twins. And so I was like, okay, it's safe to do, which is awesome that there's accessible workouts like that. But when I go to the class in person, I literally go to the back so I can hold the wall just in case we have to do any sort of like lunge series because I'm so nervous I'm going to fall. Okay, we talked about everything leading up to menopause. How do you know that you have hit menopause?
So if you are over the age of 45, and you have not had a cycle for 1 year, that is the medical definition. Now, there's, menopause is really, that's the medical definition. There's multiple problems with that, right? What if you don't have regular periods? What if you've had a hysterectomy or you have a Mirena IUD? What if you had polycystic ovarian syndrome and you really can't rely on this? Does that, you don't get to have menopause? What if it's leap year? Do we have to wait 366 days? Like, it's ridiculous we use this as the diagnosis. But if you haven't had a period for a year and you're over the age of 45, 99% of the time you're menopausal.
And then what about frozen shoulder?
Yeah. So the musculoskeletal syndrome of menopause is real. Estrogen is a potent anti-inflammatory hormone. We remove its protection, okay? And so if you see, they even call it 40-year-old shoulder, 50-year-old shoulder in some countries. And so one of the best researchers in the area right now is Dr. Jocelyn Wittstein, and she's at Duke. And I interviewed her on the podcast, and she said she was seeing all these patients who were on some of the ovarian suppression medication for their treatment of their breast cancer. And there were so many of them were coming in with frozen shoulder. And she's like, and the most likely time for a woman to have, or it's a woman who gets it, and she's most likely between the ages of 40 and 50, 40 to 60. And she's like, think there's something to do with menopause? And like all the men in the room go, no, it can't be. And turns out it is. So she did the actual studies that proved it. And it's pretty phenomenal that it took until the 2020s for us to figure out something that's been happening in all of humanity.
To everybody, like everybody experiences
it. It's a progressing inflammatory disorder that affects the shoulder joint. It could also do the hip as well.
And what does it feel like?
One of the first signs you lose, it hurts, okay? So you have phases. And the first thing is you lose some of so you can't put your arm behind a woman in a picture. You can't do your bra. You're struggling to do your hair because the joint, so it hurts and then it freezes. So it's in the joint capsule becomes actually inflamed and then scarred. And then like in the post-treatment, you have to break up the scar tissue to get it to move again. And if you have one side, it's a high probability that you're going to get the other side. And what they found is that women on menopause hormone therapy have a lower chance of that happening, of developing it, and they have a shorter course and they respond to therapy better.
Okay. So it is important to be doing the hormone therapy.
Mm-hmm. It can be.
Yeah. Oh my gosh, the frozen shoulder, when I started looking into this, I was like, that's what I'm most, and hot flashes.
I'm always like checking my movement to make sure I still have full range of movement.
What are the biggest misconceptions women have about menopause?
That it won't happen to them, that it's just hot flashes, that there's nothing they can do about it, and that hormone therapy is dangerous.
Yeah. And then if a woman does the right things in her 20s, 30s, and early 40s, how different can her menopause experience actually be?
So remember, it's not just hot flashes. It affects every organ system of our body. It is a turning point towards increasing risk of cardiovascular disease, increasing risk of stroke, increasing risk of diabetes, and increasing risk of dementia. And so what we can do is attenuate those risks by locking in those healthy lifestyle factors earlier.
Yeah, during our perimenopause years. So coming out of reading your book, what is the one takeaway you want people to have?
That they're not scared of this. That is a normal transition, but they have the tools and the resources available to help them manage this easily.
Coming out of today's conversation, what is the one thing a woman in her 20s should understand about her body that would completely change how she moves through her life?
You only get one body. And it's going to serve you, hopefully, for the next 80 to 90 years. Take care of her. Take really good care of her. Listen when your body's not feeling right. You need to listen to her and go get help.
Dr. Mary Claire Haver, how can everybody stay in touch with you and stay up to date on everything you've got going on?
Across social media, you can find me at Dr. Mary Claire. And our website is thepauselife.com. We have so many resources there for every age. We have guides, we have quizzes, we have, things you can print out and take to your doctor to help you advocate for yourself at your appointments.
Well, thank you so much for being here with me today.
Awesome.